Yeah, I asked to report that the quorum was exist for the Joint Committee of Gender and Health, Commerce, Business.
Thank you very much, Madam Clerk of this important Joint Committee. Assalamu alaikum to each and everyone present here, honorable members, SMS, stakeholders. You are welcome to this Joint Committee meeting. That is the Joint Committee on Health and Gender. That is assigned by the plenary, that is the Assembly, to consult stakeholders regarding the Women's Amendment Bill that was presented to the plenary by one of our members as a private member bill. So part of our consultation, we deem it necessary to at least put it in a all-inclusiveness approach. So that is why today we have invited you here to join us, and we see how best we can have a very fruitful meeting and also get the facts from you so that we'll be able to put it together and add it up to our comprehensive report that we are currently preparing so that we will be presented to the plenary when the session starts. So in that regards, I will just want us to, that is the members, to adopt the agenda before we proceed. If it is okay with you as presented. Stakeholders, do you also have the agenda with you?
I move that we adopt the agenda.
Second. It has been moved and seconded that we move the agenda as it is. So in that regards, I will just want to go to the third item of the agenda, which has to do with introduction. And I will start by my humble self. That is, I am Honorable Modulamin Biba, the co-chair of the Joint Committee here present today, and also the member of Banjul North constituency.
Good morning. Good morning. I am Honorable Fatisha, member of the Parliamentary constituency and the Vice Chair of the General Committee and the co-chair to this joint.
Good morning. I am Honorable Sisi Abdullah, member of the committee and the deputy majority leader at the House. Thank you.
Good morning. Honorable Musa Bagi, Taridin Kunyan constituency, also a member of the committee.
Good morning. I am Honorable Swaibu Ture, member for Woodley East and member of the Gender Committee. Thank you.
Good morning. I am Honorable Madabo, member for Open constituency and the same time member of Health Committee.
Good morning. Honorable Pat Keja, nominated member of the Joint Committee.
Can you
Sorry.
can we use one?
You have to put it up.
Good morning. Honorable Pat Keja, nominated and member of the Joint Committee.
Good morning, I'm Dr. Yahya Mohamed Ba, Software Specialist.
Assalamu alaikum wa rahmatullah. My name is Fatima Specialist.
You can help. You can help. Stakeholders, you can also introduce yourselves.
They have their mics.
You can use that mic.
Yeah.
We can start from here, please.
Good morning. My name is Maria Massa, the senior accountant of Wassu Kafo.
Good morning. My name is Fatou Nyang, community trainer of Wassu Kafo.
Good morning to all. My name is Dr. Kaplan. I'm the founder of Wassu Kafo.
Good morning to all of you. I'm Professor Abdullah Sen. I am the Executive Director of the Nyangsari Institute for Social Justice and Research.
Good morning. I am Ali Hussein, the Program Associate for the Nyangsari Institute for Social Research and Justice think tank.
Good morning. I am Dr. Ama Onesi, the Public Relations Officer for the Medical Women Association, the Gambia.
Good morning. I am Dr. Selassie Asase, member of the Medical Women's Association of the Gambia.
Good morning. My name is Dr. Kumba Vivian, and I'm advisor to the Medical Women Association of the Gambia.
Very good morning to all. I'm Dr. Safi Jame. I'm the president for Medical Women Association of the Gambia.
Good morning. I am Dr. Hassan Alzadeh. I'm a senior lecturer in obstetric and gynecology at UTG.
My name is Dr. Anna Jai. I am the secretary for the Medical Women's Association, the Gambia.
Good morning. I am Dr. Putin Jai. I am the co-public relations officer for Medical Women's Association, Gambia.
I am Dr. Chapa S. Jalo. I am a consultant pediatric surgeon with a focus in pediatric urology, GI and cardiothoracic thoracic surgery. Currently, I'm head of department of surgery of the Teaching Hospital. And then also, I'm the head of the pediatric surgery unit of the Teaching Hospital. And then I am here with Medical Women's Association as an invitee. Thank you.
Thank you very much, everyone, for that wonderful introduction. Like I said before, we are here to go through a process which is very important. That is the consultation process on the Women's Amendment Bill that was introduced, like I said, by a member to the plenary for consideration. So in that regard, it was referred to the Joint Committee, that is the Joint Committee on Health and Gender, to make consultation by inviting all the relevant stakeholders so that we'll be able to at least provide a very comprehensive report at the end of the day. So in that regard, I want to seize the opportunity again to welcome all the stakeholders to this important meeting. And before we move further to the consultation, I will just allow my co-chair to also say something. Co-chair?
Thank you very much, Honorable Chair. I think what you said all is just a consultation meeting with, because since we're dealing with the Women's Amendment Bill, which was brought by a member, as he said, so we're only trying to find facts with regards to the amendment bill. We haven't concluded yet anything, and this meeting will not to make us to conclude anything, but we are trying to find facts just to lay to the plenary, and the plenary will decide. So it is very, very important you tell us your experiences with regards to the FGMC, and then you also tell us what are the side effects, what are the implications and everything, and then we will also rely on that to see how best we can work and make a conclusion to whatever we are doing.
Thank you very much, Co-Chair. Before I will allow the Female Doctors Association, but I can see Medical Women Association, the Gambia. I will also want to inform you that during the presentation, you can just highlight the most important. You don't have to go through the entire presentation because there is also a time set for this consultation, so that we'll be able to allow other stakeholders to also share their position papers and also their presentations with us, if that is okay with you. So, honorable members, we just give the floor to the Female Doctors Association to go ahead with their presentation.
Sure.
You have something to say? Okay. Okay.
If you have some members who just sent it, they can introduce themselves.
Okay. I've been just informed that there are new members that just arrived, so we just allow them to introduce themselves before we go ahead with the presentation. Honorable member, you can take them.
Good morning. I'm Honorable Padin Busane, member of Fuji Board and part of Health Committee.
Okay. We also have other stakeholders that just arrived.
Good morning. I am clinical assistant GFPA.
Okay.
Good morning. My name is Kasamani Ture, Program Officer, Gambia Family Planning.
My name is Momo Njai. I'm the acting executive director of Gambia Family Association.
Okay, thank you. I believe now we can go ahead with the Female Doctors Association. You can go ahead with your presentation.
Thank you very much for having us today. The Medical Women Association, the Gambia, is the Gambian chapter of Medical Women International. Our parent association is a global umbrella group of medical women and students since 1919. That's over 100 years ago. Representing women doctors from different continents around the world. In November 2019, female doctors from the Gambia found it important to have medical representation of Gambian women and children. That's when we came together and formed our body, and we named ourselves Medical Women Association, the Gambia. We are 113 members strong, and some of the programs we've engaged in involve health awareness seminars at the Vocational Training Center that's next door. We've also had some breast cancer awareness programs and breast cancer screening programs at the barracks and Serekunda Market, when we've also visited the Banjul, the central prisons, Martu central prisons. And our members are part of the Gambian community. 34% of female doctors in this country are survivors of FGM, and 74.1% of our members have encountered a patient with FGM. So to start off our presentation, we thought it best to go back to the beginning, and we do a little bit of embryology and to understand how the female genitalia is formed. This way, it will be when we understand how the female genitalia is formed, the complications will make more sense. We did embryology for 2 years in medical school, but I'll give it to you in 2 slides only. As you can see, this first diagram here, this part. So as the baby is growing inside the womb, the first month, the first 1.5 months, you cannot tell if the baby is a boy or a girl. If you take a scanning at 1.5 months pregnancy, 2 months pregnancy, you will not be able to see anything. The only thing that will determine whether it's a boy or a girl would be the blood, the DNA. So at this point, we will not know. Going further to 2 months, 8 weeks, the baby will grow further, and the male baby, which has male DNA, will start producing male hormones. And when these male hormones are produced, then the penis will start to form, as you can see here. It's forming, and then by 12 weeks, you can see that the penis has formed properly. As with the female child as well, it's the same thing. At 6 weeks, you cannot tell the difference. It will be the same for the boy and the girl. So the girl baby will start to produce female hormones, and then you will see the female genitalia will form here and here. As you can see, they're almost very similar. It's just the hormones that will cause them to develop in a different manner. So if we see, here it's called the labioscrotal. At this point it hasn't differentiated, so it's either the labia or the scrotum. When you come down, it is here, this blue part for the boy. The same thing here for the girl, it will be the labia. This is important later on when we talk about FGM, because if you were to apply FGM on a male child or a male baby, it will involve cutting off this yellow part here. This would be FGM, the equivalent on a boy. If you remove FGM type 1, which is removal of this yellow bit here, the clitoris, if you do the same thing, would be removing the yellow part in a male. So it's good to understand. This is why we had to explain a little bit of embryology, so that we understand the differences and the similarities between the male and the female baby. As the genitalia forms, the clitoris, which is removed in type 1, we have it here. The labia minora, removed in type 2, and the labia majora, which is the bigger one, which is removed in type 3. Again, just to show you the male and the female, in FGM, this red bit is removed. So if you were to do the same thing in a man, you'll be removing this red bit. So it's good to understand that male circumcision is not the same as FGM. When FGM is done on a girl, you are removing this red thing. And if you were to do FGM on a boy, it will mean removing the glans penis, which is this red part. So they are not the same. As we know, when we do male circumcision, we do not remove the red part. It is still there. So we will have we've already gone through the types already. Dr. Chairman Jallo, he is a pediatric urologist. This means that he operates children with urine problems. So MWAGAM thought that it would be very important to have first-hand information, the individual who actually operates these children when they come with urinary complications from FGM. He is here and he will give his presentation on FGM in children.
Thank you, Anna, for that introduction. I want to disclaim, I am not representing any cultural group, nor am I representing any religious group, and I've not received any form of finance or any type of support to be here. So I came here on my own accord as somebody who has a special interest in condition affecting children. I am a pediatric urologist, pediatric surgeon with a very big interest in pediatric urology. To my knowledge, in our jurisdiction, probably that's how God designed it. I am the only pediatric surgeon working in this jurisdiction. I have not followed keenly some of the things that have been said on FGM, medically or from any other quarter. So I am going to talk specifically on medical, as that's an expert's opinion on this issue in a very unbiased manner with evidence-based knowledge. Moving forward, we've just been, this has been highlighted to us, that's the female genitalia. And as you can see, we've seen the clitoris here, and then this is the labia minora here, and then the labia majora there, and then the vaginal opening. Underneath here, you have the urethral opening. Urethral opening, that is the pipe that carries urine, water, and then this other one here, that's the bad canal. And then down here, you have the rectum, and then throughout this is the perineum. As a refresher, this is widely accepted and is evidence-based in the world. That FGM, this term is a medical term, mutilation. It's a procedure that is intentional, alter or cause injury to female genitalia organ for no medical reason. Further, I'll clarify, which is partial or incomplete removal of the genitalia. So in 2015, and then this term was used. This procedure has no health benefits for girls and women. This is widely accepted in all the scientific committees. And then it's widely accepted that it causes bleeding, which I have anecdotal evidence, first-hand evidence, and then it causes problem with urination, which I have managed patients, children on that. In fact, the last slide saw a condition of that. And then also cyst, which also I have a slide on that. And then infertility as well as complication in childbirth, with increased risk of newborn death. This is well documented in literature. That is beyond my scope. We all know it's commonly practiced under 15 years of age, 5 and 9 years. So meaning most of these children go through this process when they are within my jurisdiction. Because all these children with urinary problems, when we talk about urology in children, there's a close connection between the urinary tract, the bad canal, and then the rectum in children, as you will see in some of the conditions like that. For clarity, there's a clear difference, and then I would really want the Honorable to really highlight this part. People will come with different definitions. Facts are facts. If you say a human being, every human being would have a head. When you say circumcision, circumcision is the removal of the foreskin in men and also has a medical benefit. There's a very big controversy in that, but that's beyond the scope of this discussion here. But it is universally accepted that male circumcision has benefits. Some of the benefits in pediatric urology, if a child has some what we call bladder outlet obstruction, urethral valve, or other conditions that make it difficult for the child to pass urine, those ones, if you don't circumcise them, they have recurrent infection, we call it urinary tract infection. And then if they have other conditions, balanitis and other things, so those children must be circumcised. So there is no controversy on that. So, but when you come to mutilation, this is an act of damaging, removing or destroying a part that is not medically warranted. It's not only for FGM. Anything, any part of the body that you remove, not because of medical reasons, is called mutilation. Hence, the term female genital mutilation comes. And I can tell you, there is nothing like female circumcision, because we've seen from the previous presentation, what we call circumcision is removing the foreskin. And when you talk about, when you want to import the same circumcision in a female, you are talking about foreskin. And this is not applicable. Even if you stretch that discussion in the female genital tract to say you are talking about a foreskin, it will be it will be clear in our mind, this is something that is practically impossible. These are some of the reasons that have been highlighted as doing mutilations. Types have been highlighted before, 1 to 4, and then you see is removing the clitoris. That's clitoridectomy. It's not a foreskin. In fact, in some documentations, even this type 1 has been divided into 2. Some will say removing only the foreskin. And I am telling you, I have operated children more than any other person in this country. And within 2.5 years, we have done over 700 surgeries. If you should monetize this, you should look at Senegal or other countries. The amount of patients we have saved over $20 million because our healthcare is done virtually free. So that dividing type 1 into A and B, where you remove only the foreskin, doesn't exist. It's practically impossible. Even if you tell us, the doctors, to do it using microscope, it is something that will be practically impossible. And that is something that I will not advise any health worker to take that period. And then we went up to type 4, where if you do scraping. Now, I did say the scope of pediatric urology. It's from, it is very clear there is a close connection between the rectum, that where the stool is passed through, then the urethra, urine pipe, and then the pipe that carries the baby. Because when the baby is forming, these three things all form from the same place. And then while the child is in the womb growing, then they divide into 3. So sometimes no division happens. We call it cloaca. And then sometimes division happens, and I'm sorry, I would want honorables and the people here that some of the pictures are graphic. And you should take note, but in helping honorable to understand this issue to the core, I think we can't run away from its graphic nature. But I would caution that. So what we are seeing is called vaginal synechia. In babies, when they are about some time, the whole thing is closed. So we open this thing up. This is what I do. And then now, the last one here, this child have what we call clitoropega. Sometimes the clitoris get big because of a lot of medical reasons. So this child will need surgery. These are the ones that will be medically warranted. We reduce this. And of course, these surgeries are done here. So then this one you can see was closed completely. Then we open this, was done in our hospital. And then this girl too, you can see here, there's a small hole here where the poo passes through. This girl spent all her life like this because she was very thin, because she always constipates. In our hospital, we opened the rectum. She had no rectum, we opened it. Another girl, this one has what we call urogenital sinus. The water pipe and then the vagina all open in one hole. And then in that hole, water, the urine, and then that's the baby tract, it's all joined. And then also you can see what we call the clitoris the one that is mutilated in FGM also was big. And then you can see, some people thought it was a young man. And then we opened, and then we did the surgery. This is another view. You can see that's the girl, and then we did the surgery. So the next step is to reduce this thing, so that is to pull the skin down, so that attach it, so that it will look like a real female. She's very happy now. She's moving her life, and then now before menstruation was a problem because everything was closed, but now she's menstruating normally. So these are some of the things we do. Because when you talk about pediatric urology in children, it involves gynae, apart from aside infertility or menstrual problems. So this is a baby also who fell from a horse cart in our district around Kiam, came and we diverted the stool and we did a repair. So meaning that we are involved in repairing the female genital tract. Now, this is so. So you come here, you can see this young man was circumcised. After circumcision, it was completely closed. This child was not passing urine, the kidneys almost failed, so we had to now refashion it. So now this one you can see there's only one hole, the rectum, the stool pipe, the urine pipe, and then the back canal all open in one hole. So what we do, we separate all of them, and this is, so now from a start you can have the stool, the pool, so that the child is able to poo. Then after we use the colon, we make that the vagina, and then that tract, we give it to the urethra for the water pipe, and then the rectum, we construct that. So we are doing all of that. Now, you can see this child had FGM. The child came with urinary retention, was not able to pee. Then the renal functions were all down. So when I saw, what I did for this child was we had to plasty. I opened the urinary tract, and they also had a cyst. I did the cyst. So this is a different child. Another child came, is having, we call this implantation cyst, post-circumcision. Because what happens, when you do circumcision, when you remove the clitoris, then the skin gets embedded, and then it grew. We call it implantation cyst. And when you look at it, you will think it's a form of phallus, a form of penis. And then the family also worried they came. You can see, you will think it's a young man now. And this was a complication of circumcision. So what did we do? We removed, you can see the cyst is here. That's the cyst, and that's the cyst here. And then we did. After the reconstruction, I tried to reconstruct something that would look like minora, majora, but the clitoris and then the minora were all chopped off. So, but we were able to construct so that it looked like something that's normal, to just reduce the psychological impact that this baby could have. So, if you look at it by and large, anecdotally, we are seeing complications of mutilations on our babies. This is existent. Some come with urinary tract infection because the water pipe is closed. But sometimes everything is scarred, including the urine pathway. And sometimes skin gets buried there, it forms a cyst, which if you don't do anything can have dire complications on the child in the future. So I think I will tell the honorables, in the mind and everybody listening, I think we should not confuse circumcision and mutilation. Circumcision is the removal of only the foreskin. And mutilation, in fact, saying mutilation is circumcision is a misnomer. Misnomer means a name that you are applying wrongly. And I would want, as an expert who's been working on this thing, I have been a doctor since 2007. I would advise that we desist from using interchanging mutilation and circumcision. These are two completely different terms. They are totally different. They have different meaning. They have different connotation. And I would want that to be put on record. Thank you.
Dr. Jallo has gone over the complications of the urine system. Dr. Azadeh will now talk about the complications seen during childbirth and sexual dysfunction.
So, yeah, can we expect on the voting on this medical notice one? No. It's based on the pictorial area. Will they come back? The picture sorry, yeah, what I mean, the picture, there are something, the picture. Whether if they all come, will we go back to the pictures to put it out? We go. Right.
Thank you very much for giving me this opportunity as a senior gynecologist and obstetrician to give some explanation. Is that
Hello, hello.
The mic. Okay. Thank you.
Okay, go ahead.
Okay. Once more, thank you very much for me to have this opportunity to discuss this topic. We are here, all of us are here to discuss about it, and I am a senior obstetrician gynecologist at UTG, and my colleague, Dr. Jallo, has extremely good presentation about the children, when the children getting circumcised, or eventually as a female genital mutilation, we call it. But those children being cut already at the age of maybe 3 to 8, most of them, they grow up to a teenage age, where eventually intending on eventually getting married, getting pregnant, and as soon as a young girl starts menstruating at the age of maybe 12 to 14 years of age, the gynecological complications started. The gynecological complications are they complain about the painful menstrual periods, and the discomfort of the general thymus as well. And when they eventually get pregnant, this is another difficulty for the child being circumcised, now grow up to the young woman, and the problem started when they get married, when the scar has been deep in front of the vagina, and it must give the vagina's area very tight. So they will have difficulties for the penetrating of the husband into the vagina. Anytime they have trying to have contact with each other, there is very painful and very difficult for them to really cope with that. And the worst thing, it comes when they are pregnant and they come to deliver the baby in the labor ward. I give you a statistic about the circumcised or FGM in the Gambia from WHO. In the Gambia, we have about 86.6%. I repeat, 86.6% of women are circumcised. So there is a two-thirds of the Gambian women are circumcised, and they are coming and becoming all these complications during the labor. It is very difficult for a woman with deep scar of circumcision scar to deliver a normal vaginal delivery. And we cannot actually, because of this circumcision, we cannot take every woman to do a cesarean section because the baby cannot be delivered through the vagina. So these complications of the women, it means from the childhood, a child is being circumcised until become the age of even menopause, is disabled, has got complications, health complications, and the sad things of that is that most of the women being deeply circumcised, being deeply gone under the FGM, they become childless. Infertility is one of the commonest, and that is due to frequent infection in the vagina and transferring to the womb, and when the fallopian tubes are blocked, so there is no chance for the women getting pregnant unless they go to an IVF, and this is obviously more costly and more difficult to do that. I would like to emphasize actually that there are some slides that we can go through. I would like to emphasize what Dr. Jalo very clearly just shown, the meaning, the Oxford dictionary, medical dictionary of mutilation. The mutilation is actually the removal of any tissues, of any organ, of any human without no medical indication. Those organs, they are healthy. Those organs God has given to the woman, and they are part of the body. When this being cut, and there is absolutely no medical indication. Dr. Jalo myself emphasizing that is something we doctor, we should ever even think about it. Against our oath we had that we are lifesavers. When we are lifesavers, obviously then we will ever harm somebody. And that is what we are here today to discuss. We are medical doctors. We are not going in different issues of meaning of FGM. But for me, maybe not the same like Dr. Jalo, there is no difference between circumcision and female genital mutilation. Why? Because both of them is cut, and the cut is completely, there is no medical reason to be cut. But the mind eventually have some different idea, discussion about it. And Dr. Jalo has definitely focused on every single complication. Even as a child, as a baby, as a child, a young child, and then when it comes to and the other thing I would like to mention as a gynecologist, the clitoris is an organ God has given to the woman. There is a gland with nerves, with blood circulation. that is actually to be touched by the partner when you have a sexual time. But you cannot take any sexual desire from the woman by just cutting the clitoris. The sexual desire of the woman, they come from the ovaries, from the sexual hormone of the woman. So the sexual desire of the woman will not stop when you just taking part of the vulva, which is the outside the vagina. So when we say disable the woman, it's because its clitoris is being cut totally unnecessarily, and for the rest of her life, she suffered with social complications, in particular when it's come to obstetric, with getting pregnant, carry on with pregnancy, and when it's come to delivery, to have complications of that. I think we can have someone.
I would just want to remind you again, if you can just summarize, because we have other stakeholders.
Yes, so I'm Dr. Vicki Jai. I'll just be taking you through the misconceptions of the health benefits of FGMC. And so we did a survey of our members. We had mentioned that we have 113 female doctors. And we asked them, of 63 who responded, we asked them, do you know of any benefit of FGMC? And a staggering 98.4% said no, they do not know of any benefits or health benefits of FGMC. Now, the 1% that did know of benefits share the same misconceptions of the general public who do think there's health benefits. So I'll just take you through that quickly. So the first one is that FGMC may contribute to hygiene or cleanliness. A study that was done by Morrison et al. In 2001 in Farafenye of 1,300 women showed that there's actually an increased risk of genital urinary infections in women who have had FGM. And needless to say, but I'm going to go ahead and say it anyway, gentle washing of the genitalia with water is enough to maintain your hygiene and your cleanliness. Secondly, the comparison to male circumcision. I think that point has been labored here. But whereas male circumcision has proven benefits, there's multiple studies that show that yes, if you are male and are circumcised, you're protected from A, B, and C. There's no proven health benefits of FGM. And in our circles, in the medical circles, there's arguments that if the labia or the clitoris do persist, what I mean by that, if it's not cut, you can then get adhesions, etc. However, this is in a small minority of women, and it usually happens in adults and not children. Another common misconception is that type 1 FGM is the most common in our setting or our communities, when it is not. It's actually type 2. And there was a study done by Udoko et al. That showed that actually type 2 was the most common. And the study I mentioned above, Morrison in 2001 in Farafenye, also showed that type 2 is the most common. And lastly, beautification. So this is actually not a myth, it's a fact. Some cultures have different perceptions of beauty, and this applies to the female genitalia as well. So some people see the female genitalia as being more beautiful, it's more symmetrical and more smooth, and this is perfectly okay. We're allowed to modify our bodies as we see fit. However, the problem here is that FGM is being done on a subpopulation of young girls who don't have a say of what is happening to them at the time. So this is called female genital cosmetic surgery, and it's one of the fastest growing fields of cosmetic surgery, where a woman will come in and request A, B, or C done to their genitalia. Again, this is in adults, and the difference here is we're practicing this on girls who do not have a say. Next slide, please. So in conclusion, I will just quickly go through our opinion statement, but before that, I want to touch on the issue of medicalization of FGM. This is basically performing FGM or health workers performing FGM. So we're totally against this because this is never acceptable and it violates medical ethics. I have said this already, this is being performed on young girls, babies as young as 1 week old, who do not have a say in what's happening to them. And their autonomy is basically being violated. So medicalization also perpetuates FGM, and the risks of the procedure outweigh any perceived benefit. Again, of the survey that we did of the 63 female doctors, they were asked, are you in support of medicalization? And 88%, that's the bar you see in blue, said no. And are they in support of repealing the Women's Amendment Bill? Again, 96% said no, and these numbers cannot be ignored. I'll quickly go through our statement or our opinion letter. The Medical Women's Association, the Gambia, opinion statement on Women's Amendment Bill 2024. We, the Medical Women's Association, the Gambia, are writing to express our collective opinion on the matter of repealing the law banning female genital mutilation cutting. Our stance is informed by extensive medical literature and data on the global, regional, and local prevalence of FGMC. In the Gambia, FGMC prevalence stands at 96.3%, with type 2, removal of the clitoris and labia minora, being the most common practice, not type 1, the partial or total removal of the clitoris, as is widely believed. The practice of FGM is recognized internationally as a violation of the human rights of girls and women. This practice confers no proven medical benefit and therefore could be seen to reflect a deep-rooted inequality between the sexes and constitutes an extreme form of discrimination against girls and women. Nearly always carried out by traditional practitioners on minors, it could thus be regarded as a violation of the rights of the defenseless children. The practice also violates a person's rights to health, security, and physical integrity, the right to be free from torture and cruel, inhuman, or degrading treatment, and the right to life in instances where procedure results in death. The purported medical benefits of FGMC are minimal and primarily pertain to adult procedures, such as female genital cosmetic surgery. However, these procedures are not without risk and lack sufficient evidence to support their efficacy. The medicalization of FGMC, condemned by global health bodies, exacerbates rather than mitigates the practice. Medicalization violates the principle of medical ethics to do no harm. It must always be remembered that although many of us are privileged to wear many caps, our primary one must be that of a parent, after which we may be clinicians, lawmakers, and various sorts of government officials. We therefore shoulder enormous responsibility to fully protect our girls and women and not to predispose them to added vulnerability of which they are already seen to be by virtue of their gender. We therefore implore our National Assembly members to uphold existing laws, strengthen enforcement mechanisms, and invest in comprehensive prevention strategies, including education, community engagement, and access to health services for all Gambians. Let us join hands in forming a big concrete ring to protect our girls. Thank you all for your time.
Thank you very much for that marathon presentation. And I believe it will be very useful to the committee. But like I said, we have limited time as far as this important meeting is concerned. So what I will just do is, honorable members, can we allow them to present the other stakeholders?
No, they are going.
Yeah, you want to go? Okay. So we can now give the floor to the honorable members, and let's limit the questions so that we can have other stakeholders who also do their presentation. Yes, Deputy.
Thank you so much.
You can use the mic.
Do I have mic? Is fine. I just wanted to ask, because the first presenter, just for clarity and on records, because it's important for me. That is to say, you talk about circumcision, the difference, circumcision and mutilation. I understand the terms on women is the same, but then circumcision is done on men. If I'm right?
Yes.
Can you hear me?
Yes. Yes. No, that's not what I said.
No, I'm not saying that's what you said. I'm just trying to, I don't know how Madanko used to say it, just trying to lay down the foundation. Like I'm saying, circumcision You know, when you project, you say removal of foreskin. That is circumcision, and that normally is done on men, not so. So you talk about mutilation. I just wanted to confirm. If you talk about circumcision on women, circumcision is only done on men and not on women. That's what I wanted to confirm. Exactly, that's what I wanted. Yes, on records.
You are right. That's what
Good.
Yes. Yeah.
That's fine. That's what I wanted to confirm on record so that I can, get that done. Thank you.
Thank you very much. Dr. Jallo, this is just for confirmation's sake. You said you've conducted over 700 surgeries on issues relating to...
No. What I said was for children, between these three things, the stool, the pipe that carries the stool, the pipe that carries water, and then the pipe in the future through which babies pass through are all connected, they all have the same origin. So because of that, as a pediatric surgeon, these three things are things that we are trained to do. So in general, because this problem that we are seeing is commonly done less than 15 years, and then this is the population we engage as pediatric surgeon. So that's why that statistics.
I think in your comments, not only on the slide, in your comments you said you operated on you mentioned a figure.
Yes, exactly.
Is it correct, like 700?
Yeah.
So that's what I'm saying. I want to spread that in a period. Is it because considering the fact that the practice has been banned 2015, now these surgeries happen after the banning?
No, what I got number is all the surgeries.
All the surgeries?
Yes, all the surgeries.
That's what I'm saying. I want to position it within a period. If after the banning, 2015, because some of these victims are kids. So I want to confirm, understand. Are they victims after the banning?
The ones we did?
Yes.
I came to the Gambia in 2008. I started, to be very precise, January 2002. So today we've been operating. So now for complications of FGM,
yes,
are things that we battle with. From bleeding, I remember that's about 7 girls, and then when they come, usually they come with old women, and then they're quiet. They said, this child is sick and is bleeding, and then of course we are trained to be very sensitive. We respect everything, and then we very religiously and culturally correct. So we are always non-judgmental in our dealing with these patients. So we go ahead, we help to stop the bleeding, and then the ones that who came with implantation cyst will be solved with retention, which you do. But while even we are doing that, they will advise you, they will tell you, we don't want you to correct or do anything that will revert what we did.
Yes, so among those surgeries, only 7 were FGM related.
Only 7.
Like you just mentioned.
No, I'm talking about
have statistics.
Yes, anecdotally, yes. That's for bleeding. So for implantations, there are about 3, and then for retention, there are about 2.
Yeah.
So now these are the ones that came to us. So and then the way most of the patients that comes to us, especially with complications, they come very late. And then I don't know what other centers receive, what is done from other places. But I can tell you, these patients I saw, the 3 implantation cysts, 7 came bleeding, and then the ones with retention, which we did in the arthroplasty for, are all FGM related directly.
So is it possible, is it correct? Because there is this suggestion that it can be medicalized, meaning to take it to be conducted at the medical level. And you are saying that is impossible. So I'm just coming. Is it possible to say, is it correct to say, because there is this suggestion that this foreskin on the clitoris is very tiny, that only the microscope can see it. Is it possible to remove it with a microscope? And my last question is, Doctor mentioned about the 86% of Gambians went through this practice, women. I'm interested to know that, but I want to validate that statistics, because I was thinking, when was this statistics, the 86%? Which period was this? Is it after the ban? Is it very recent, up to date, or something like that?
We have printed out one of the most recent research that was done in the Gambia by Doko et al. And this was in 2010. 2010, yes.
The 86%?
No, this one is the 76%.
76%?
Yes, this was done in the Gambia. The 86% is WHO. So the one we have, WHO, you have
Yeah.
I would, which year? Yes. And you had a question?
Yes, for the surgery. Honorable, considering, I know this matter is of essence, considering our condition as a low-income country, and then the difficulty that this will bring, not even to talk about control, I would advise that we don't take this route. Even with microscopy, because the clitoris and the foreskin is the same. It's one, from the expert's perspective, there is something that I don't want us to be boxed in. Saying that there is a female circumcision. The clitoris itself, the thing that has been highlighted, all the tissues around are the clitoris. So what you are removing, you are not removing the skin, you are removing the clitoris. This is what you are removing. And then that itself is mutilation. Medically, there is no benefit. That's the word mutilation. So using circumcision for mutilation is a misnomer. And I think from medical perspective, this is something that we should desist from, because we are equating or applying something that doesn't exist. So at the end, any decision that is taken on that would be erroneous and would be based on a foundation that's not correct. So at the end, with time, we will all realize it is something that we did that was not correct. So mutilation, you can never use circumcision on a woman. In fact, it's type 1 to type 4. In trying to still squeeze in circumcision in that, even that type 1 has been divided into A, B, just to squeeze it. Now A, now you are saying foreskin, and I am telling you that thing you are saying is this is the skin. Everything is the clitoris. So that's the information I'm trying to send out from the medical perspective, from a perspective that we know the genesis of how the genitalia grew and then the equivalent of the clitoris in the female and then in a man, the gland. That whole thing is the clitoris. So whether you remove the skin, you chop off, that one doesn't exist. So that's what I know there is a lot of controversy, but this is something very clear. and then in a very unbiased manner. And I disclaim here that I am not representing anybody.
Dr. Jallo, right? I think that's clear.
You know, in the course of this process, many witnesses pass through.
Yes.
So what I'm bringing is from my own perspective. It has to contrast it with other information that we have received.
You know, what we're doing right now is going to help us a lot. Like I said in the beginning, this is a consultation. And during the process, we must, as members, ask questions so that we can clarify some of the things. Because some other stakeholders came here and said different things.
That's what, yeah.
So now, we are on record. We want things to be clear, because all what we are doing at the end of the day is what we're going to take back to plenary to decide on behalf of the people that we all represent. So in doing so, we must make sure that we clarify things to the extent that we also understand it. So that is what we are doing as members currently. And I think you've really clarified so many things that have been asked by members. So what we do is we just move to, I think, Honorable, you can go ahead.
I can go.
Sorry, Honorable.
Yes, thank you very much, Mr. Jallo. Dr. Jallo. I think one of my questions has already been clarified. That you cannot tamper with the criteria without dealing with other aspects of the vagina, which causes a lot of complications for women. That's clarified now. Now, you have also some issues locally that the reason why they are putting this clitoris is because it grows. When a person is growing, the clitoris also is growing. If you don't cut it, it's like the person, a male will look like, a female will look like a man. Would you clarify that to us? Is that true?
No.
Well, can we also make it very soft?
So also on record, I, as a pediatric surgeon, the first and the only Gambian pediatric surgeon, and the only one working in this jurisdiction, I can comfortably tell you it's wrong information. Of course, the human being starts from the womb, grows, comes out as a baby, grows until an adult. All the part of the body grows. Looking at the clitoris, there is, it never, anytime you see, I operate 13-year-old, 15-year-old, 16-year-old, it's uniform. The ones that are not circumcised, the clitoris, it's all uniform. Of course, that is why I showed some pictures here. There are some diseases that causes what we call clitoromegaly. Yes. So some clitoris are big. That is a disease. So when you see a clitoris that is bigger than normal, that is a concern, come to us. So when we do what is called clitoral reduction, that is a disease. But normally, it should not grow beyond the normal. If it happens, it's a disease, and a disease called congenital adrenal hyperplasia, it happens, you have what we call clitoromegaly. And then in some other diseases that are hormone-related, it happens. And then there is a 27-year-old girl, the girl was born in our hospital, went through our system here. And then the clitoris, when you look at it, it's so big, it looks like a phallus, like a man. And then, in fact, they thought it was a man. And then the girl was going in and out. They wrote a medical report for her to go overseas. When I came, she was around 19. So we took over the case. In fact, she had only one port. So we opened that. Then we doing the clitoral reductions after doing the opening the vagina and all that. And then 2 clitoral reduction we did clitoromegaly. So those ones are disease. It's sickness. So that's what this thing is all about. But the problem I have is you can't use sickness to justify something that is normal.
think that is very clear. But before other members come, I would just want some clarity in terms of your presentation. Was there any drop as far as the practice is concerned since the passing of the law? That is, if you have that information. And yet still, I am a little bit confused when you say FGMC, or FGC rather, and FGM, that there is no female circumcision. That's what you said, right? But according to the law that is presented to us for amendment, it's talking about the prohibition of female circumcision. So what do you have to say about that? Yeah, that is what the law is saying. That is section 32A of the Women Amendment Act. It's talking about prohibition of female circumcision. So what can you tell us about that?
You know, we have different experts in this country. Even in the health fraternity, there is a lot of division in this issue. But what I can tell you is a misnomer, is a name that's not correct. That name needs correction because there is nothing like female circumcision. Of course, even my colleagues within, some have different views, but I just tell them, put on your doctor cap. Do you agree with me? Or I agree with you, but I say, okay, fine. So I think in dealing with this issue as a medical practitioner, as a surgeon, as somebody who has interest in reducing morbidity and protecting suffering and making sure patients are alive, I can tell you clearly in an unbiased manner, with no string attached, and then without expecting any dime. If you put $1 million in my pocket, you want me to be reversed, I will still tell you, and I can tell you openly, that there is nothing like female circumcision. If it's in our books, please review it. Thank you.
That's clear. So,
Yes.
No, my question has been taken care of.
Okay.
Thank you very much. Dr. Jallo, we must commend you and your team, including Dr. Hassan. I knew him at a very early age. Yes, I just have one question. Somebody, a pediatric surgeon who have a lot of health background, apart from these videos that you projected before the members, do you have any other mechanism to put available to the public domain to compel this rumor that FGM have a health benefit and not harmful?
I believe as an organization or as an association, we are obliged to educate the public, sensitize the public, and we have been doing so since our inception. However, one of the positives that has come out of this conversation or this discussion about FGM is that sensitization towards FGM needs to continue and we need to redouble our efforts. So I don't think we have had anything directed specifically towards FGM, but we do plan on publishing some information on our social platforms and maybe reaching a wider audience and just taking on the mantle of educating girls and women as we continue to do, but specifically putting FGM forward in that aspect.
Okay.
Okay, thank you very much for that presentation. Dr. Jallo, I have a question for you in connection to Honorable Abdullahi Sisse's question with regards to the circumcision and the mutilation. You've made mention of removing the skin for the man and of course the clitoris for a girl child. So, you know, in some presentations here, we do hear that there are 3 types of whether circumcision or mutilation as mentioned here. So can you confirm to this committee what are the 3 types of this mutilation that you're talking about? And then also in these 3 types, is there any way that they only remove the skins of a girl child? rather than the clitoris. Thank you.
Thank you. I am a medical doctor, and I avoid anything that is outside that scope. That's why probably it's the first time some of you have seen me or had me talk. Forums are there. I don't engage. But if you ask me about my medical knowledge, what I know, what is clear to me, what I work with day and night, and then I engage in reconstructing the vagina using the colon. I engage in reducing the clitoris if it's big. I engage in refashioning that place to make it look normal in children. So if you talk about FGM, that's mutilations, and in children, there are 4 types, there are not 3. And then the first one is called clitoridectomy. That means we cutting the clitoris. Some will cut it partial, some will cut it completely. That's clitoridectomy. That's the first. That's the one. That's number 1. So now nobody's talking about skin. Nobody's talking about these are all their own tissues. Nobody can look at the clitoris and say this is the skin. This is a gland. It's the gland itself. So now, because medicine has to be culturally correct, and then medicine usually it depends on jurisdiction. There is some form of dilution. So now in that drive, some divided this one into 1A, 1B. And 1A, then they said just removing what they call hood. That's skin. And I am telling you there's nothing like hood. The whole thing is the clitoris. In sanctioning, saying that you just remove the hood, you are calling for the removal of the clitoris. Then 1B now is said the clitoris. Then number 2, it's removing the clitoris. In addition to that, then the labio minora. Minora is the opening just after the opening of the fetal tract. It covers the water pipe, urethra. It also covers the vagina. So the whole thing is removed. That's number 2. Number 3, some call it infibulation. That is removing everything and closing it. So now, you know, in that place, we call it vestibule. That whole place is called vestibule. And what we call vestibule, there are 3 holes, 2 holes there. The water pipe, the urethra, and the vagina. So when you cut, you close everything. It means you have also closed the water pipe. So we all know, and then if the water pipe is closed, the person can't urinate. We all know the consequences of that. So some of them will have those complications. They will be leaking quietly. They go on with those complications, renal failure, and then when they die, and there is something that is disheartening in our environment, and then we will go beyond that. We don't do postmortem. And anytime somebody dies, I agree, culturally, if the culture says, when somebody dies, you bury the soonest possible that you do. But most of the distinct patients are buried, and the only one who remembers this baby is the mother, the father, and the immediate family, the siblings. But nobody remembers when a child dies. So that's the end. And then nobody even, so that's how the story goes. That's number 3. Then number 4 is all the 3, then scraping the place, piercing, you know, in a very barbaric manner, as if that genitalia is a monster, that you must deal with the monster. So, but it's clear from statistics that about 86% in the Gambia here is type 2. That is, you remove the clitoris on the Gambian children. I don't know anything about women, about adults, but on the Gambian children, in the Gambia here, almost 85%, they remove the clitoris and then the minora. So what is left now is just the skin covering that place. It means you've removed everything. So that is what we are looking at. So now, the other argument that may come is that what about if you just remove the clitoris? It's a mutilation. So as a country, as from the health perspective, if I should give my word, I would say this is something that we should not invest our energy on, and then rather we should look at other their need situations, and then we protect any child from suffering from any form of mutilation. And then we should not agree, especially our honorables, that anybody to come here, be it from a ministry, be it from anybody, be it from any quarter, to tell us that there is something called female circumcision. Thank you.
Sorry, I have a supplementary. The meaning, based on the explanation, there are, instead of 3 types of mutilation, it's 4 instead. Thank you.
All right, I think that is clear. Before I ask a question, but it is not yet answered, about the practice, whether it has dropped since the passing of the law. Because that also needs to be clear. We also want to have a perspective on that area.
The latest data we have is 27.
Family planning wants to answer something.
Oh.
Yeah, based on DHS 2019-2020, there's a slight drop.
There's a slight drop.
Yeah, of from 75 to 73%.
Then that's clear.
From?
Honorable, you want to ask?
From 75 to 20.
Yeah, can you make it short and precise so that we can allow other stakeholders to give their presentation?
Okay, thank you so much. Thank you, Honorable, for giving me the floor. What I want to ask is, maybe if anyone of you can answer it. Normally in girls or women, sometimes when they are in their menstruation, some of them go through some difficulties or pain. Some of them even feel sick during their menstruation period. I want to ask whether that thing has anything to do with FGM or cutting.
Dysmenorrhea. You mentioned about.
Yeah. Your question is whether they get kind of dysmenorrhea. Is that right?
Yeah.
Dysmenorrhea, it means pain during the menstrual period. Due to this scar, actually, and combined with infection they have in, they get difficulty by having a normal menstrual period. So by FGM, dysmenorrhea and infections, they are quite common.
Do you understand? He's not saying there is a cause.
I can. And to add on to that, so women and girls who have had FGM can have dysmenorrhea, and women and girls who have not had FGM can also have dysmenorrhea. I think dysmenorrhea is one of the things that we've just accepted as part of womanhood, unfortunately. So it happens to all of us. However, this can be exacerbated or increased or worsened when you have certain types of FGM. For example, the types where there's infiltration, where the opening is closed. So now here we have type 3. So now here we have a small opening where your menstrual flow is supposed to flow through, it accumulates, you can have infections. The pressure from it accumulating can be painful as well. So I hope that answers your question.
Okay, I think that is clear. We, on behalf of my humble self and the entire membership here present, and my co-chair, we want to thank the Female Doctors Association for that insightful presentation, and also for ably answering our questions, because these are questions, like I said, that will help us a lot in in terms of preparing a very comprehensive report at the end of the day. So in that regard, I also understand that you're supposed to leave because you have other engagements. So I will just seize the opportunity to release your team and allow Young Sane Institute to do their presentation.
Sorry, we cannot hear you.
He's talking to the chair. Chair will relate.
Yeah, it has been brought to my notice that you came as a team, right?
Yes.
Okay, so I on behalf of the members, I am thanking the team.
Thank you.
Yes. And we really appreciate your presentation. And if you can also share what you have presented and also your position paper to the clerk, we will also appreciate it. So can we move to Young Sane Institute?
Absolutely.
Professor.
Distinguished National Assembly members, staff, ladies and gentlemen, I am Professor Abdullah Sen, and on behalf of the Young Sane Institute, I thank you for your kind invitation and really feel honored to be here. Many of you may wonder why I was selected by my peers at the Institute to testify on FGM. I have, for the last quarter century, been an advocate for human rights and women's rights and dignity in particular. In my first lecture on FGM was over 25 years ago. I was invited to Minnesota where I gave a lecture. This was unusual. In fact, some of the men and women walked out of the lecture because this was taboo. In 2001, I was invited to Oslo, where I also gave a presentation on FGM. I should hasten to add that I'm a retired professor of political science, political economy, African studies, and international relations. And I have focused on this, in particular, in all courses that I teach. So really, I bring to this conversation a lot of research, teaching, and service. Let me digress quickly and say a little bit about the Young Sane Institute. Some of you may have already heard about the Suleiman Yan and Lamin Sane Institute for Social Research and Justice. Now, these were two renowned, globally recognized Gambian scholars who taught respectively at Yale University and Howard University. And they have been known for their passion for social justice, interfaith dialogue, amongst other things. So we celebrate them for their contribution, not only to Gambia, but to the world. In celebrating these two giants, we also celebrate all Gambians. In fact, if we were to give this institute another name, it would be the People's Institute. It is a bottoms-up institute. It is not a status quo institute. It is focused primarily on problem solving rather than reducing or introducing and producing data that can be consumed and left aside. Primarily, the Institute is interested in providing data for decision makers like yourselves. The Institute is also committed to social justice, just very quickly. And we are also very much committed to supporting government and its process of transitional justice. In other words, we are victims oriented. We are focused also on the marginalized in our society. Women, girls, the differently able, and so forth and so on. We are also interested in supporting diasporans in their quest for the vote. So these are really some of the things that the Institute focuses on. What is also important to emphasize is that we are very much interested in interfaith dialogue. This has been a primary focus of the Nyangsana Institute, and in particular, Professors Nyang and Sani. Now, let me very quickly propose that the Nyangsana Institute believes that safeguarding the rights and protecting the health and safety of women and girls is one of the most important functions of government. We therefore support, as an institute, the Women's Act of December 2015, which makes provisions for banning female genital mutilation. We believe that repealing or amending such an act will be a bad decision by the National Assembly, that will reverse the many years of social progress Gambian women and girls have enjoyed since the passing of the Act. We believe that the religious arguments being made for repealing the Act are not supported by sound references to the Bible or the Quran or sound hadith, as the case may be. In fact, there are so many respected scholars, Islamic scholars, who believe that there is no relationship or support for FGM in Islam. In fact, recently, at the OIC meeting held just a few days ago in Gambia, it was unanimously disassociated with Islam. So really the arguments made on Islamic grounds have really not been supported by Islamic groups, universities, and scholars. We also believe, as a result, that there is no sound basis, really, for FGM in any of the existing religions in the Gambia. We believe, Your Honored committee members, that FGM is harmful to women's health and safety. This has been made very clear by the medical team. The practice has no health benefits for girls and women and causes severe bleeding and problems during urination, cysts, infections, and so forth and so on. And of course, childbirth is oftentimes complicated. So these have been borne out by the evidence. And there's really universal agreement that these are the side effects that FGM has. Therefore, the Nyangsana Institute urges NAMS of all political parties to vote against a repeal of the Women's Act 2015. Let me just conclude by suggesting that the Nyangsana Institute is premised primarily to provide information, data, so as to help decision makers in their attempts to provide good, enduring, and useful decisions. Thank you so much for your time. And I could dilate more if you have questions or concerns. Thank you so much.
Thank you very much, Professor Sen, for that presentation. Honorable members, do we have to proceed with other stakeholders considering time so that we can just add up the questions? Yeah. So now I will just allow the Gambia family planning to take the floor.
Thank you very much.
The mic.
I can connect on the screen and but nevertheless, yeah, it's not on PowerPoint, but it's on Word. I can be ready, and I can also, so that people can see what we are trying to do. First of all, I want to also acknowledge the presence of Dr. Harris, who's a gynecologist and a consultant at the Gambia Family Planning Association. Dr. Harris, you're welcome. Gambia Family Planning, our vision is to ensure that quality sexual reproductive health and rights for men and women in the Gambia and young people. That's our GFPA promotes sexual reproductive health and rights, including family planning and fights against gender-based violence, HIV/AIDS, through advocacy, counseling, behavioral change communication, and the provision of healthcare services for couples, individuals, and the underserved, especially the young people. The government of the Gambia adopted the legislation against FGM in 2015, which we are all aware, and since then UN agencies and government and non-governmental organizations, partners, are engaged in creating awareness on the harmful effects of FGM while at the same time popularizing the law. Female genital mutilation refers to the procedures involving partial or total removal of female external genitalia or injury to female genital organs for non-medical reasons. FGM, acronym, violates girls' and women's rights to health, security, and physical integrity, rights to be free from torture and cruel, inhuman and degrading treatment, rights to life, and rights to sexual and reproductive health. The law cannot stand alone, cannot be a standalone. More intensive sensitization on the health complications of FGM must continue side by side with awareness creation on the contents of the law in order to achieve the desired attitudinal behavioral change required for total abandonment of the practice. The abandonment will be more effective and sustainable once people decide to stop the practice because they are convinced that the practice is harmful to the health of the woman. An assessment conducted in the Gambia in 37 health facilities from 2013 to 2016 and validated in 2017, that is female genital mutilation in 37 facilities 2013-2016, assessment of data quality and obstetric and delivery complications and their management by the Ministry of Health reveals, amongst other things, the practice resulted in these following things. What I'm trying to quote here is that there was a study taken in the Gambia in 37 health facilities existing in the country, running from Banjul down to Koina, looking at FGM registers and assessing the data. That is, it was started in 2013 and ended in 2015 and validated, 2016 and validated in 2017 by the ministry. So I think this is local data that we are talking about here, not international data or international conventions. So basically, what it says is that it causes perennial tears, fresh stillbirths, and needed episiotomies, septic tears, or EPIs after delivery. It also causes a lot of pain to women undergoing labor, repeated urinary tract infections, and vaginal bleeding, and also causes fetus distress. This was revealed by a service provider in Kerewan during the study and during the interviews that have been taking place. In the same story, a service provider in Bansang is quoted as saying that FGM can cause health implications during labor and delivery and prolonged delivery and can cause tears. So you see, they're all speaking of the same language of the causes this can result. Nevertheless, numerous studies have shown that FGM is associated with the risk of health complications such as urinary tract infections, bacterial vaginosis, painful sexual intercourse, obstetric difficulties. Also, the deliveries of women who undergo FGM are slightly more likely to be complicated by cesarean section, postpartum hemorrhage, and prolonged maternal hospitalization than those women who had not. This was revealed by WHO in 2008B. Therefore, GFPA thought it fit that this alarming rate of complications, the public should be adequately sensitized on the effects of FGM, with greater involvement of men in supporting the eradication of the practice. Because this is administered to women, we feel that men should intervene, and in the Gambia, the tradition is men are the custodians of the house. So basically, without their involvement, a lot of misunderstanding may come up. So that's one of the issues that we feel that we should be involved. According to reports, FGM on women and girls can result to anemia due to excessive bleeding during mutilation or delivery, infection due to absence of aseptic techniques during mutilation, painful sexual intercourse, and loss of sexual libido. It further results to obstructed labor as a result of narrowing the vaginal passage, which leads to tears and fetal distress. There exists high potential for transmission of STIs and HIV, STIs and AIDS, due to the use of the same cutting tool, knife or a razor blade, in the circumcision of several girls. What we mean here is, when you're performing the act, you may use one knife or one blade to 10 or 15 or 20 girls, which can contribute to the spread of HIV. And it can lead to, even when the lady gets pregnant, PNTCT, PNR. So that's why we said. Nevertheless, since the law has been instituted, there is still, we cannot say nothing has been done. Something has been done and something has been achieved. And this is revealed by the DHS in 2019-2020, which reveals that the prevalence of FGMC in the Gambia has decreased slightly since 2013 from 75% to 73%. And that traditional circumcisions account for nearly all circumcisions, 98% for girls and 95% for women in the Gambia. Less than 1% of the girls and women were circumcised by medical professionals. So you can see, so it seems that most of these things, or majority or all of these things, are being practiced by women without medical equipment, without medical or sterilized equipment. In addition to the identified health effects, there are negative social consequences related to marital disputes caused by relatives' low appetite for sex amongst women who underwent FGM. This could affect women's matrimonial lives, because sometimes you have these cases which women complain. For girls, when they are newly married, their husbands find it difficult to penetrate them.
Sir, can you please repeat? Because you did mention about there's a certain percentage of the practice that was done medically.
Yeah.
Medical condition. Can you repeat that? Because members want to be clear.
According to the DHS 2019-2020, reveals that the prevalence of FGM in the Gambia has decreased slightly from 2013 from 75 to 73%, and that traditional circumcisions account for nearly all the circumcisions. That's 98% for girls and 95% for women in the Gambia. Less than 1% of the girls and women are circumcised by medical professionals. That is, if you go to the DHS 2019-2020, you'll find it there. It is also a driving wedge among communities as women who have not undergone the practice are being discriminated and stigmatized as being not clean at times when conflicts happens. Thus, repealing the Bill Women's Amendment Act 2015 anti-FGM law would undo the considerable gains made in safeguarding the rights and well-being of women and girls. Furthermore, reversal would potentially weaken the resolve of other nations undermining the continent's collective struggle to eradicate FGM and overshadowing many lives throughout West Africa and beyond. Finally, we respectfully urge the National Assembly members not to support the bill to repeal or reverse the Women's Amendment Act 2015. Regardless of what we have said, we also have some recommendations which we want to put across for consideration by this honorable body. One, build capacity of service providers to skillfully handle cases of FGM patients to alleviate pain and suffering during labor and delivery. 2, consolidate the gains made in the fight against FGM. It is believed that the ban on the practice is not enough to eradicate it, and that efforts aimed at sensitizing the public on negative health consequences of FGM must be intensified. 3, continuous massive sensitization, especially on healthcare providers, community advocacy, trying to involve key people within the community to head the campaign. Because sometimes you may want to educate most of the communities, but heads may say, I don't believe in this, I don't believe in that. You know, these challenges come across. So we need to do massive sensitization with a view to convince these community leaders to make sure that the ban goes in place. Educate and support the people with FGM complications and highlight to them the reasons for such complications. This could help them prevent their children from undergoing the same procedure. Because any woman who has undergone this, we need to educate her. Tell her what the reasons are, why she is undergoing such, so that tomorrow she will not allow her daughter to undergo the same practice. Women who underwent FGM could be provided psychosocial support, such as counseling, can help alleviate the trauma and pain and they may have suffered or continue to suffer from as a sequel of FGM. There is need to integrate FGM sessions in schools through peer health programs to create awareness on the dangers of FGM to young students with a view to eradicate the practice in the next coming generation. Because all we are doing is adult-driven education. What is happening to our children at the schools? They don't know. So if we start doing it, by the time they grow up, by the time they are mature, they will also not practice it, but their generations to come will not often be involved in that. So that's why we are putting in this recommendation. We are not saying, sometimes it's very difficult to change it into the curriculum, but if we start, many schools have peer health education programs. If they integrate it into their programs, it may help also educate a lot of them, so that at least they can make an influence on some of these things. Develop resource mobilization strategies and proposals to sustain eradication of FGM, and also support improved socio-economic status of victims of FGM. What we are trying to say here is, we develop proposals, we develop strategies. Because whatever we are talking about here, if we don't have the strategies, we don't have the resources, some of our strategies will fail. So we need to do it as a joint, take it as a joint effort to ensure that we develop resources, look for develop proposals, look for the resources, and sustain the campaign. With that, we think this Honorable House will be able to help. Finally, although banned, the scars, wounds, tears, and sutures of FGM will continue to affect the reproductive health of girls and women for many generations to come. Thank you very much.
Thank you so very much, sir. Now we just move to the representative from Wassu Kafo. Yes.
So can we just ask these people?
Yeah, because I am also considering time. We are already run out of time. Yeah, so I will also expect Wassu Kafo to.
Yeah, the last one.
Yeah, they are the last one. Just to be very short and precise in their presentation. You don't have to go through all the slides. Yeah.
Chair, may I have an objection? This is a national call. Time is readily available. Let's exhaust the questions and allow Wassu also to come, because they are making a presentation. If we cannot hide behind time. No, what I mean is, no, the suggestion that, okay, I second what I was saying, that we ask questions to these people, because Wassu is giving a presentation, so that we can exhaust those ones and go on there. The time is at our favor. Yes,
but allow them to present. So the questions
let me say something. Even the issue of time. This meeting is scheduled for a period of time. And we must respect that, because other committees will come and use this. This rule. Or until or unless you want us to continue outside, if that is okay with you. No. I'm just suggesting, if that is what you want, because you have to propose something that is possible.
Okay, I propose, because I know other committees, when they come, I went round and see there are 2 rooms that are currently not engaged. We will tell them the magnitude and the sensitivity of this bill need to be exhausted. You understand? We can go to the clerk and tell him, we know currently a sensitive magnitude of bill have not come such at this level. Let's scrutinize it to the latter. Yes. We have questions. You see why we don't ask questions to other people? Because of the time.
We understand that.
Let's ask these people to questions, then Wassu Kafo come. That's my suggestion.
Honorable Member, I don't dispute that, but we all know as members, we have a lot of questions to ask. And if you can allow me, can I please manage this meeting? Yeah, please. You want to say something?
Yes, yes. I think what is important for us to do, the documents that they are going to present, and they will give us
they will submit it to the class.
This is the most relevant thing that we can get from them. Their opinion on FGM matters, but of course, what you have, when you will submit to the committee,
exactly.
That's more important. So what we can do is, the time is 3 hours, and I think we also have to respect the class. Probably has a meeting at 1:30. So once we are done with you, the process now will help the committee to take the decision. That's the most important part here.
Yeah, Ma, you can go ahead.
Thank you.
Doctor.
Well, good morning again, everybody. Thank you for the opportunity for Wassu to come back. Again, we presented a long health consequences in the Gambia on the 3rd of May. So we are really thankful for being able to summarize and present our position paper. I do echo what Gambia Family Planning was proposing, all of it, so I will not go through it again. Okay. I will just quickly present who Wassu is. Wassu is a Gambian NGO established in 1999. I've been here in the Gambia since 1989. I'm a medical anthropologist and professor at the University Autónoma of Barcelona and a member of the steering committee on FGM at WHO in Geneva. We have a transnational observatory. We have 40,000 Gambians in Spain. So what we have is a transnational observatory with 2 research and knowledge transfer centers. One in the Gambia and the other one in Spain with diaspora. It's longitudinal. We've been working on this for 34 years, and we have an innovative approach which is scientific, respectful, holistic, and sustainable. As you can see here, we have the Transnational Observatory, and what we do is applied research. And this applied research is then transferred. The results of the knowledge gathered through applied research, we transfer to different stakeholders. We have a memorandum of understanding with different.
So what is your Gambian?
Your Gambian name?
My Gambian name?
Yes.
Honorable Jawara. Honorable Jawara. That's a very indiscreet question. Mariama Sibojanke. Mariama Sibojanke. But then she wants me to say Juba. Because in the village they call me Mariama Sibojanke Juba. That's what she wants. So, Wassu Kafo thinks that what we can bring knowledge, we can produce knowledge, we can transfer knowledge, we can design programs, but the responsibility is from each of the institutions. So for us, it's very, very important to have unsigned MOUs with the different institutions to work together. This is the responsibility of them. We can produce knowledge and we can work together. And for us, it's very, very important to work with the government, to work with different institutions and sign this MOU because it means that they recognize that FGM is a health problem and that we have to work on it. This is the methodology, the generation of knowledge through applied research, and we come down, okay, to the National Assembly. We've been here in 2018 or 2019. Government, ministry, judicial institutions, when the law came out, we trained judges and magistrates. Medical doctors, nurses, midwives, public health, social workers, teachers, judges, and magistrates. And then we go to religious and community leaders, traditional birth attendants, circumcisers, village health workers, CSOs, and NGOs. And we come down to women, men, youth, and girls. This is a transfer of knowledge in cascade. So this is what we have been doing between 2010 2023, and we have reached 13,747 beneficiaries. And you see we keep control of every training we do, and in every region we work. So we know who we have reached. And then this is very important because we're talking about something that we need to do, which is monitoring and evaluation, and how we have impacted in the ground. So it's important that you know where we have been and go back 6 months later, 1 year later, 3 months later, and ask what have you been doing, what are the hard knots you are finding to move on with this. Okay? You cannot just go to a village, deliver and leave, which is something that is not routine. Because today you talk FGM, tomorrow you talk oral rehabilitation, and 2 weeks later you talk HIV or COVID. Okay? You need to go back, you need to talk, you need to find out what are the problems, what are the hard knots to know, and to help them disseminate the information. So we follow the WHO recommendations. The Wassu methodology follows the recommendation to build evidence, to provide guidance, and to do advocacy. And of course, we are supporting, the Gambia is supporting the SDG, the Agenda 2030, with the promote gender equality and empower women, reduce child mortality, and improve maternal health. And FGM is under 5.3. So FGM in the Gambia, I'm not going to extend because it's been explained widely. We have 70, according to UNFPA 2022, 75.7% of girls and women aged 15 to 49 years have undergone the practice. And the prevalence rate is lower among younger cohorts at 51% among girls 0 to 14. Meaning, we have improved. We have made impact. We are moving forward. And this is very, very important. We are in the right way, okay? With respect and with knowledge. Respect and knowledge, to me, are the two key ingredients to move on, okay? So, 49% of girls and boys aged 15 to 19 think FGM should stop, which is a big change in youth. And then we have 70% of adolescent girls reported undergoing FGM before the age of 5, which is something that we know that the age is going down. And in one of the questions that you have done, has FGM stopped since the law? What we know is that the age has gone down, and they cut babies because they cannot talk. Okay, so this is answering to one of the questions that you asked before. The prevalence in the Gambia varies through ethnicity and geography. So you have Sanhulas 97.8, sources DHS 2019-2020, Mandinka 96.7, Fula 87.3, Jola 87, Seren 43, and Wolof 12.4. So I think it's important to know that even in Senegal, Wolof don't do it. In the Gambia, some of the Wolof do it. Maybe because they marry Mandinkas or they marry other ones. So this is the map. And I don't know why it came small. But as you can see, it differs in the geography because it has to do with ethnicity. So you have in Kanifing 71%, Brikama 78, Banjul 48, Kerewan 42, Mansakongo 80, Kuntao 54, Janjanbude 61, and Basse 97. So you see, it has to do with geography, it has to do with ethnicity. So, evidence into action. I'm not going through all this because you have the precedent speakers have presented and we have no time, but I want to present clinical research done in the Gambia, and Wassu has done the two first clinical researches in the Gambia. The most important one that you can we can gather information and data as you requested. The purpose of this study was meant to build the capacity of midwifery students in the field of research. Because when we were training, when we introduced into the academic curriculum FGM in all health science, and this is a flag for the world because Gambia has been the first country in the world who has developed an academic curriculum specifically on FGM and introduced in all health science. So to follow the first presentation, FGM was introduced in embryology, physiology, anatomy, gynecobstetrics, pediatrics, community medicine, and psychology in the career of medicine. Okay? And this was exported to Kenya, Tanzania, and Senegal. So I want you to know how high the flag of scientific work and how good this methodology can be in terms of being respectful, knowledgeable, and routine, okay? That is a model for other countries. And I think we need to be proud of this. So we were training the first batch of midwives. They were very, very experienced nurses, but they didn't have the title, let's say, of being midwives. So we trained them in Masakonko, and they were very ashamed because they are really proud of the profession. And they said, well, you know, we have seen all the consequences that you are presenting, but we never link them to FGM. We never link them to FGM. So they said, is it possible that during the 4 months practicum that we are going to have with antenatal care and deliveries, if Wassu can come, supervise, and you know, we can collect data. So what we propose is to make a comparative study between women with FGM, women without FGM, and the complications during delivery and the suffering for the newborn. Okay? So it was meant to build the capacity of midwifery students in the field of research to improve their skills and knowledge in identifying and managing the complications related to FGM, to compare deliveries with and without FGM, and compare the health complications of the newborn. Everything is published in scientific articles. Okay, so anybody willing to read more, in our web page you can download everything. Okay. So the population was women that came to the hospital or to the health center for antenatal care or delivery, and that have gone through FGM or not. The sample size was 572, which is a high sample. It was done in the Western Division, at that time called Western Division. As I told you, midwifery students, and the duration was 4 months, December 2010 to March 2011. And the variables were ethnic group, typology 1, 2, 3, by WHO, complications related to FGMC, by questionnaire, delivery complications, and for the newborn. And one more thing that you ask about FGC, female circumcision, FGM, dash, how do you call this? In English, how do you say this?
/C.
/C. This was a big debate, and in 30 years this debate is on. Okay, so generally it's FGM, and FGM includes the 3 types, the 4 types. The 4th type is a type that, you know, that for good or bad, the steering committee of WHO has 2 anthropologists. So until many years ago, it was only type 1, type 2, type 3. But we included, and we asked to include type 4, because type 4 is done not by primitive cultures, but by developed cultures in industrialized countries. Okay, so it was meant because we are talking about piercing, we are talking about dry sex, we are talking about female cosmetic surgery, we are talking about other things. Okay, so FG, female circumcision. Why female circumcision? We work very close with the other vice president, Aisa Tunjai Sedi. She was a sociologist and she wanted to know. Okay, so one thing that she said is, me, I've been cut, I've gone through the practice, but I don't want to be called mutilated. So basically, it's a sign of respect to talk about female circumcision and not female mutilated. Okay, but it's just in terms of respect to women. But female circumcision is female genital mutilation. That is clear, that is no doubt. The only thing that sometimes you talk female circumcision for respect to the woman. Okay, so I hope that some things that were coming, you know, I'm just picking up questions that you had and answering. So, what are the results? We had a majority that at that time was type 1, 18 type 2, and 0.3 type 3, and 25% of women that came to these hospitals during the 4 months, 25 did not have FGM. So what are the findings? The findings are that perineal tear is 64 with no FGM, 71 with type 1, 76 type 2. The episiotomy practice. Episiotomy is when the baby is pushing and there is no elasticity. Okay, so what you do is you do a cutting to pardon me?
To expand.
To expand. I'm making an effort, I think. Okay, so you see the difference between no FGM, type 1, and type 2. And fresh stillbirth, women without FGM had 0 stillbirth, type 1, 70%, and type 2, 16.3. So I think that those numbers are very short and to the point and are very clear with this. So women with FGM are 4.5 times more likely to have delivery complications and babies with health complications. You see here we have with no FGM 7.9 and with FGM 35.2. And these complications are due to the loss of elasticity produced by FGM and abnormal scarring like fibrosis, synechia, and keloids. In terms of neonatal complications, I think it's very interesting because you had 3.6 complication with no FGM, 22.4 with type 1, and 32.7 with type 2. So all forms of FGM, including type 1, produce significantly high percentage of gynecological and psychosexual complications. So, now to medicalization. I think it's very important. It has been presented before. I'm just going quickly to remind. FGMC can never be safe. There is no medical justification for the practice. Even when the procedure is performed in a sterile environment by a healthcare provider, there is the risk of health consequences immediately and after in life. It may confer a sense of legitimacy of the practice or give impression that it has no health consequences, which can undermine efforts towards the abandonment. When performed by health professionals, FGM violates medical oath and ethics. And I think that every good professional, every ethical professional should follow what the oath he has done. Medicalization is not the way forward and should not be accepted as a safe alternative or a high, lower risk thing. In regards to what was presented before, that health professionals under the public health system, we did a KAP, knowledge, attitude, and practices among health professionals and students. 42.5 supports the continuation of FGM, and 7.6 reports having performed FGM during their medical practice. I think this is a reality. Everything is scientifically published. You can go to the articles. So medicalization is already a reality in the country. Conclusions. All forms produce significantly high complications. Women with FGM suffer painful menstruations every month. We have been hearing the presentations. Women with FGM suffer frequent urinary infections. We heard the urologist. Women with FGM are 4.5 times more likely to have delivery complications, more likely to suffer perineal tear, are much more likely to deliver a dead-born baby. Babies born from mothers with FGM are more likely to suffer fetal distress, and women with FGM are much more likely to suffer gynecological problems. So, the Gambia should honor, this is something that maybe we didn't take in consideration, but we have been so fortunate and so honored to have the OIC conference in the Gambia. Yes, and the OIC is fully against FGM. In 2013, they already talked about this, and on the 6th of February 2024, they remade the same statement. So the Gambia should honor national and international conventions. I'm sure that the lawyers have been presenting all the conventions, because as a modern democracy and sovereign country, the Republic of the Gambia is a signatory to many national and international conventions to put in place legal instruments to the protection of women and children's rights. The organization of the OIC condemns FGM, and they say we can no longer allow ignorance surrounding women's rights and FGM to be perpetuated by traditions and rituals disguised as religious teachings. This unhuman practice has survived for over centuries and it must be stopped. And I think this is very important to take in consideration. And then we are honored to have President Barrow as chairperson of the OIC, and he needs to follow what OIC is saying. So His Excellency has become the new chairperson of the OIC, and the Gambian Parliament in 2013 has ratified the Women in Development, which also calls for the eradication of FGM in all OIC countries. So, just to finish, girls, the studies demonstrate the high magnitude of FGM health consequences in girls when FGM is practiced, women all lifelong, and in particular during delivery, and newborns due to a longer and more difficult delivery in women with FGM. So we echo what Gambia Family Planning was presenting. There is need to train health professionals and health students of health science to identify and manage the complications and consequences related to FGM, counsel, sensitize, and prevent among communities. Wassu has developed a manual with 10 modules for health professionals. These 10 modules are the content of the training we give to health professionals. With the MOU with the Ministry of Health, we have designed and we are implementing the national training program for health professionals on FGM. This is the content of the 10 modules, but to make it sustainable, what we did is to introduce these 10 modules into the academic curriculum of all health science. Okay, and this is the first in the world, and it's been seconded by Kenya, Tanzania, and Senegal. Thank you. I tried to be short.
No, that was good. Yeah, that was very good. That was very good, and I think that presentation will be handed over to the secretary of this committee, because we believe it will be very useful during the compilation of our report that will be presented to the committee. So in that regards, I will just open the floor to the members so that they can ask questions to all the three presenters that have already presented, so that we can wrap up from there and close this session. Honorable members, the floor is open. Yes. Yeah. Honorable Touré, go ahead.
Thank you very much for all the presenters. We've had quite an information from all of you. But my question will first go to Dr. Sen. I would have thought that since your organization is engaged in social science research, and if it is related to FGM, you would be able to help us to explain where this concept of FGM comes from, why, originally, what was the thought, and if you have done some research on FGM also, which countries did you conduct your research, and what was the reaction of the people when you actually conducted the research in those countries? Just give us a brief explanation.
Thank you so much for your question, Honorable. In our policy document, we give the background as to the origin. It is pre-Pharaonic, pre-Islamic. In fact, it is suggested that, large swaths of the West African, East African, part of the Middle East areas do practice different forms of FGM. There are some sociological, anthropological, as well as political factors that gave rise to this practice. For some, it's aesthetics. In some of the presentations, it was mentioned that the clitoris could in fact be seen as a penis. And that duality is oftentimes seen in some societies as being, for lack of a better word, two genders. So by cutting the clitoris, then you become a full female. In some other instances, it is suggested that FGM has the potential of making a person more acceptable as a marriage partner. In our own society, women who are uncircumcised have a particular name, and it discredits them. So for marriageability, women are forced into undergoing this process. What we are interested in, as my research has shown, and many others have, we are interested in the human rights element. We are also interested in the power dynamic that is embedded in this entire process. Now, if you look at it from a sociological, political, and anthropological perspective, there is a power dynamic. We interrogate, in other words, the whole edifice of patriarchy and the implications that patriarchy has on the practices. At the end, or in the end, if we were to strip, from our own perspectives, if you were to strip all the medical, the sociological, the political, it can be boiled down to a question of power and power relationships. And beauty is a socially constructed notion. What that basically means is it varies from place to place. But it is those in power, the men, that oftentimes define a marriageable partner. In other words, it is consensus built around these ideas and practices that have been embedded in the practice as well as the tradition of patriarchy. So for us, we are interested in deconstructing the ideology that surrounds this practice. And ultimately, we propose that this practice is nothing but the control of female sexuality. It has nothing to do with all the religious or cultural. It can be boiled down to the control by men of female sexuality. And man patriarchy, in general terms, is used, and if possible, violence can be used to maintain dominance of men. In fact, the mere fact that this is being talked about in this day and age, and we commend you for doing that, is in itself violence against women. We contest. because I believe that there could be other things we could be talking about rather than this subject. So in a nutshell, this is the kind of research we do. This is social science research that is driven by theories of postmodernism and many others that I've talked about. But in a nutshell, we talk about that in a question paper. Thank you. Time didn't allow me to get into all that.
Yes. My first question was to family planning for that informative presentation. But I don't think family planning runs a clinic, right?
Yep.
Yes. So I was expecting some, because you do antenatal, postnatal, and all those stuff.
Yeah.
And I do know that since the higher percentage of women go through this process, majority of your birth also will be victims or survivors of this. So I was looking forward to some data with regards to the women who pass through your clinics, their complications with regards to those that are survivors with FGM. That was what I was looking forward to. I don't know if you have it or you've been collecting that data because you interact with them. So my second question is, this is for any of them who can answer, because we are lawmakers. Now we are neutral in this. When we interact with you, yes, we are not taking position yet, because law is for the people. It should reflect the wishes and aspirations of the people. It's not for me per se. I can have a personal view with regards to it, but if the law is for the majority of Gambians, it should reflect what they want. Now, my question is, since the enactment of the banning of FGM, now the prevalence rate has dropped just by 2%, from 75 to 73. Now, my question is, that law that do not support, that do not stop the people to conduct that social activity that they are doing, for the majority of that people, is that law for those people? Yes. Anyone? My second question is, because we interact with our constituents, and because 75% of them, or 73% of them have gone through this, and even we interact with women who have gone through this, and they've given back to 5, 6, 7, some even 8, and they don't recognize having suffered any complications. Of course, Madam said, his survey, yes, maybe you have a different perspective. I'm saying my perspective. I'm directly dealing with people. They are telling you, women who have gone through it are still recommending me to take their kids there. You want to tell me they see complications? So I don't take that. I said I don't have positions. I'm telling you, relating to you, what my interest. I have to go back to my community. Now, I have met a woman who, even during the banning, brought somebody from Lame to her own house to hold her own kids to subject them through this. So that is telling you that your statistics with regards to reduction is irrelevant. Because even though the law is there, the women continue to take their kids, subject them to this, because there is something ingrained in them.
Yes.
You understand what I mean? So that is my, because to make their position is that the data that are being presented are isolated cases, just like even a formal surgery, it can be faulty. Somebody can go to surgery and die. Yes. Somebody can go to and die. We are interacting with the people. So I want their intellectual position. That's why I'm bringing information from the community, so that you hear what they are saying. So I want a reaction to that. Okay. That the scenarios we've been exposed to are not prevalent with regards to the consequences and challenges and fun, because most of them tell you, man def nako, journal, I've done it, my children have done it, we all gave back, we've not seen anything. What's your reaction to that?
I'll be happy to address.
Yeah, any of them.
Yeah, go ahead.
I want
I also want to.
Yes. Now, Baji, is it Baji?
Right, yes.
Yes. This is a very important question. And one of the things that is so insidious, also problematic about FGM and how it is located in our society, is that women, in the process of growing up, are socialized into accepting these norms of beauty that are superimposed on them by patriarchy. In other words, sometimes women are their worst enemies, or best worst enemies. Growing up, the concept of beauty, growing up, wanting to get married, and the standards of beauty that women have to meet are oftentimes superimposed on them. So a woman who wants to take her child is in many ways responding to social and societal pressures so that she can have a grandchild, she can have a dowry, a marriage price for her daughter. In other words, they want the best for their daughters. I think the problem is that these kids are not old enough to make those decisions for themselves. There's another concept I want to introduce, which is ideology. There is ideology that is very obvious, but there are some ideologies that are very latent. We react to them, we absorb them without knowing it. Boys will be boys. It's very ideological. We justify, in other words, the behavior of boys. We also, in many ways, condone what boys do. When boys are promiscuous or they're salacious, oh, that's fine, boys will be boys. On the other hand, when girls experiment with their sexuality, they are called all kinds of names. In a nutshell, there is a deeply embedded ideology in our society and other societies that in many ways limit the possibilities as well as the choices that women and girls have. And this is all predicated on ideology as well as patriarchy. I don't know, I could go on and on, but this is where I'll stop.
Thank you.
Go ahead, go ahead.
Okay. Your question was about the prevalence from 75 to 72%. Yes, so why it is so small? I tell you, because we are talking women 15 to 49 years, meaning that once you count these women, you will count them again and again and again until they're 50. Okay, so the difference in this is not quite relevant. Okay, what is relevant is that we are talking girls from 0 to 14 years. The prevalence is 51%. So we are counting new people, new girls that have gone or have not gone. So I think that this is a figure that was not taken in consideration before. They were just counting married women from 15 to 49 years. Okay, so maybe that is the question why it's so small, the difference.
So the new ones are now 51?
Yes.
That means there is progress?
Yes, it's what
it
I'm
has
saying.
to reduce drastically from 70. We're looking at the new ones.
Yes.
Okay.
So I think this is very encouraging because, you know, the way we're working is working, okay, it's respectful, it's knowledgeable, and I think people is accepting it because the message you're giving is a respectful message and it's a knowledgeable message. You have data taken in the Gambia with Gambian women, and this clinical research that we have presented, it was representing the Gambia in 2011 in Mauritania. There was a colloquium of Islam and FGM. Islam and FGM, and it was imams, ulemas, muftis, ustas from West Africa, and it was the only clinical research done in the region. Yes, and we came out with a fatwa because they understood that Islam is not allowing harm, and this is harming women. Yeah. So to answer this in terms of prevalence, another thing that I think we need to do, we need to do a new study, okay, to know also the variations, to know the girls and what age. We know now they're taking it underground at earlier babies. They take babies. So we need to know more. What are these changes? What are the trends? And then you also mentioned complications for all. No, not all the women suffer complications. Some do, some don't. Yes, most of the complications can be during delivery, but also dysmenorrhea, the very painful periods that they do have. But as always, sometimes you can have complications, you cannot have complications. But if WHO is taking this in consideration, it's because, with all the problems in the world and the sickness in the world, if this is taken in consideration and you have a steering committee specifically on this, it's because it seriously affects reproductive health. Yeah. So this is what I think I answered.
Excellent.
Yeah.
Excellent. And family planning. Family planning. Yeah. Question.
Yes, please. Honorable, thank you for that question. About the data, the good thing about the Gambia is that the records book are the same in almost every facility.
Okay.
And in every facility you go to, in a records book for deliveries, we have categories, the type of FGM that the healthcare personnel would document based on what he has assessed or she has assessed on the client at the point of delivery. We did not come with that data, but it is documented in record books. You also talked about women giving you feedback about how they've been able to deliver up to 8 children. Yes, it is not about not being able to deliver 8, 9 children, but how was the delivery? We are advocating now in modern obstetrics that women should enjoy pregnancy. Delivery should not be a painful, subjective, some kind of experience that you don't want to remember. It should be a joyful something, and that's what we want women to enjoy. Now, rightfully so, a woman can undergo complications, and that complication has been taken care of by the healthcare personnel. Yes, it is not every woman who has FGM that will have or experience complications during delivery. That's a fact. But most of them do. We don't even talk about complications during delivery, sir. But I would want to quote in our local language some of these, the statements I received from women. Doctor, Mandumade, how Madubane he said. We don't talk about it because obviously in Gambia it is taboo or to talk about sex and these experiences. But personally, working with women and being a very open person, my clients are always open. And I meet women week in, week out, coming to me concerning that issue. Yes, they have a right. When you talk about reproductive health, there's also sexual health. And they have a right to also enjoy what they're doing. But I beg you, sir, that woman who has delivered 8 children will never talk to you about her experience during intercourse. Her experience sexually, she wouldn't be that open to talk to you about it. And yes, thank you, Professor, for talking about cultures and traditions. I think I'm being very cautious and careful of what I say in this, because it's a very sensitive issue nationally. Traditionally, I would want to say it is something that we have been doing for generations. And if this thing has been seen as a norm, it is going to be very difficult to change the perception of people and their attitude towards it. But then, what is a beautiful thing about humanity is that we are very, very adaptive to change. And as we are moving forward, as we are developing, as humanity is going forward, we want women to experience and have better experiences in life. And these are some of these interventions that we are advocating for changes and positive changes to happen. Yes, thank you very much, Wassu Kafo, for that data. Very interesting data. So it shows that the law is really having a positive effect. You talk to women who come to you, let's say they have been given in marriage and they have problems for penetration. It's very common. You meet them very common. Unfortunately, if they take it to the traditional ladies, it's another pain upon pain. But by the time they come to you, a health personnel who knows what to do, at least you can give local anesthesia, help them, counsel them, and that gives them that relaxation. Now, she has given us data that if we look at girls from 0 to about 15 years, the prevalence has gone down. That is positive. Of course, in women who are above that age, those women are going to be delivering, and every time they come to you, you're going to doctor the same time. But then you see the positive effect. Younger women in this generation, thank God, Gambia has a university. Gambians our level of education is going high. Talk to young ladies about this. Are you ready to have your child undergo FGM? No, and that is what we are seeing from our data. So I continue to encourage this August body to stand in for progress, to stand in for a positive experience for women in standing against repealing this act.
Thank you very much. How many plus?
Yes.
Yeah, you can ask. Go ahead. Yeah, use the mic.
Yes. Thank you very much. Again, to family planning. During your presentation, you mentioned about 1%, less than 1% of this FGM is done through medical practitioners. There are people who think that you can medicalize this. And there is a statistics which says 1% is done through medicalization. Maybe your statistics would help us all the more to know what type of FGM. Because the doctor that has left was talking about people who have problems, and those are the ones that they deal with medically. But this other 1% that you are talking about the normal FGM that is done through the practitioners themselves. Just a clarification on that.
Yeah, the 1% is data from the DHS, Demographic Health Survey, which is done every 5 years, looking at the demographic situation of the country, all the practices, medical practices that are happening, FGM, delivery, family planning, you name the indicators. And once they ask, this is validated nationally and internationally. And our development around the SDGs, some of the SDGs use this DHS to measure the achievement and level of achievement of the SDGs that we have achieved. So basically, I'm quoting from that study, that this is what the study has said. Really. But if you want to go through institution by institution, it's really very difficult to measure all these things. So basically, that's the reason why.
And this particular one is which year?
The report is available.
It's available.
DHS. I can give you. It's even here. So you can even send. If you had an email, you can just send it to the email. Rather than printing it, because it's going to be a very complicated.
The clerk will usually do that.
It's a website.
It's on the website, yeah.
It's on the website.
Just DHS.
Yeah,
you see that.
So, Honorable, may I listen to say that female mutilation is not a service provided by any health facility in the Gambia. It is not a service that is offered through Ministry of Health. So, in collecting data, you interview different people. So the people you have interviewed can tell you that, yes, this person did it for me, who's a nurse, who's a doctor, excuse me if it has happened. But this is not a service that is provided by the Ministry of Health in the Gambia. So let me hasten to make that clear.
That's good. Can I make a comment?
Thank you. Just to complete your very good information, I think that it's important to repeat that we need to have a strongly ban any form of medicalization because of what was said, and because it can become a new source of income. Okay, and this we need to take it in consideration, that when your pocket is getting full, you're happy and you keep doing it. Okay, so it has to be a very strong ban on medicalization. Yeah, because in Egypt, for example, Egypt at the moment should have about 90% prevalence, 89-90% prevalence. You have 12 million Coptic women, Christian Coptics, that they practice FGM, and they have banned Coptic, the Coptic Christians. You have 12 million in Egypt, and they do practice FGM. So they prohibited medicalization of the practice, but still about 70% they do medicalization, and they don't know how to stop it. And even the other day, maybe 2 months ago, a girl died in the hands of a pediatrician, okay, who was doing it. So our position is that very strongly you ban the medicalization, because this is not only going in Egypt, it's going in Sudan, it's going in many other countries where medicalization is going on a race. So I think that if you adopt this position of not withdrawing the law, it has to be very clear that medicalization should not be allowed.
Yes, Professor?
Yes, I was just going to make a cautionary note about data-driven evidence. It's very important, and it cannot be sidelined. Yes, thank you. But I think what we really need to pay attention to are the root causes, the ideas, as these two honorable gentlemen have identified. We must begin to not only talk about data, but really what gives rise to this data and these kinds of behavior. And fundamentally, I believe, it has to go down to education. This is what we talk about in our paper. And sensitizing individuals, more gender parity, empowering women. And our society is very conservative for all intents and purposes. And this is, I believe, where we must begin. Honorable Baji, I was going to take note of your contention that the law, in your view, from your position, is neutral. Well, what I'm saying is the law really serves a particular purpose. It reinforces ideology. It reinforces power dynamics. It reinforces class and class differences, gender differences. And the law really, in my view, and what we do in our research, is to see the role that law plays in society. It maintains power relationships, subjugation of people, and gender, and so forth and so on. I just wanted to make that note. And to de-emphasize, to some degree, power dynamics driven by the data we're talking about. I think data is very important, or are very important, but we must not go overboard with the so little miniature differences that the data may tend to highlight. People can lie and do that lie with data. Thank you.
Okay.
Yes, I don't seem to get it when you mean I said, okay, the law is neutral. What I'm trying to drive at is I'm trying to provoke reaction with regards to the effects of the law, with regards to its impact. Because when the law is in place, but still there is high prevalence of the practice going on. So I want to provoke some reactions with regards to your expertise, and
right.
that's the purpose of that question. But not per se, that is how I yes, but based on the analysis that is projected here, that's why I have to have extra information with regards to the impact of the law.
I get it.
Yeah, so but people, that's what I said. Most of the area questions I ask here is because an opportunity to provoke your action, not based on my personal.
Absolutely.
I
get it.
Yes.
Yeah. Yeah. You can go ahead. 1 minute, please. 1 minute. Yes.
No, just to follow. Just to follow what Professor has said, I think that it's very important to know that culture is dynamic, because we are the ones that produce culture. We reproduce culture. And I was just thinking when you were talking how important this is, and the qualitative research is also extremely important to understand the numbers. Yeah. So what you said, I wanted to reinforce what you were saying. And I remember when I came to the Gambia in '89, there were many people who were having scarifications. Do you remember?
Yeah.
Okay, now you don't do it anymore. Does it mean that you're less Fula or less Mandinka or less Sarahule because you don't have this? No, culture changed because people change and because we know more things. So I think that is something also that I wanted to reinforce. For Gambia family planning, I encourage you that all the data and the opportunity you're having, because as Professor said, the real way of knowing figures is exploring. And you're having this opportunity, so I really encourage you to please take note and get together and move forward, because data is always requested. Okay, and
yeah, I think that's it. Thank you very much, Doctor. Actually, what I'm going to do right now is just to hand over the mic to my co-chair for her to do the closing remarks. Then we will wrap up. Honorable members, we can wait when we allow them to do. Then we treat the last agenda, that is the
Yes, thank you very much, Honorable Co-Chair, and thank you very much, Honorable Members, and of course the Able Clerk of the Committee, and also I will thank the witnesses for brilliant presentation, for a comprehensive presentation, because as I said earlier, this is just a fact-finding. It's just to gather the information that will help us at least to lay in plenary, a report that will be laid in plenary for the plenary to decide on whatever we are to decide for the people of this nation. So on that note, I thank each and everyone who came here and to answer to our call. And the honorable members, I thank you very much for being here. Thank you.
Thank you very much, Co-Chair. So in that regards, we just allow you to leave. Thank you very much.
Okay. Thank you very much. Thank you very much.
Thank you. Your position papers, please share it with the clerk.
Okay.
Yeah. Thank you.
Sorry.
A very nice meeting. Okay.
So now, what's the matter? I said I can give you my contact.
Okay, yes.